Welcome to the final installment of our three-part series. Let's wrap things up with another great conversation.
Well, to dig into a little bit, your research has highlighted the underdiagnosis and undertreatment of the disease. Can you characterize some of the key challenges in addressing those gaps in care? And what interventions or tools have you developed to improve diagnosis and treatment? And I guess one of them is you've just addressed, right? Like, talking to 400 doctors and evaluating what people's perceptions of the condition are. Can you take that on?
Yeah, so I think I've spoken about the challenges really, haven't I? And I think, what we need in terms of the research evidence and the changing hearts and minds. In terms of tools to to improve diagnosis and management. Um, in our research, we're hoping to take a sort of two-pronged approach. So one is a tool for the healthcare system. So that's automating case finding to make it easier for healthcare professionals so that they can press a button in their health record in primary care and get a list of who needs some sort of bone health assessment and even order it so they've got the highest risk people at the top. So if they're time poor, they can really go where it's needed most. Because I think probably, as you alluded to, the people who need it the most are probably the least likely to get it at the moment. And then, so that's thinking about what the healthcare system and the workforce need. Um, Secondly, is thinking about the patient practitioner interaction and the patient understanding and beliefs and shared decision making. And so we've developed a lot of resources around that, including decision tools to be used within the consultation and afterwards by patients on their own, and also by clinicians to help them navigate the guidance. So to really just try and help the clinician know what to do and know what to offer, but then have a really good quality conversation afterwards around what osteoporosis is, what that means, why it's important, and what the medicines actually do. Um, and then aligned to that, it's also supporting that workforce, supporting the healthcare professionals and what they need to deliver that. And as I said, it's quite a specialist area, and there's a lot of support and education and training needed around that. And thinking flexibly about who in the workforce can do this, because actually it doesn't need to be GPs. There's lots of osteoporosis can be very multidisciplinary, and physiotherapists, pharmacists have got an awful lot to offer.
Just yesterday, it was the seventh anniversary of the death by suicide of a young man, my oldest friend's son, and learning a lot about suicide and the sort of things that can lead to suicidal ideation. And it's not just mental illness per se; it's anything that impacts our perception of being well. And you've highlighted the impact of significant mental health consequences of osteoporotic fractures, leading to an increased risk of suicide. Um, is that because there's a perception that I'm getting old, perceptions of aging, right, which you've referenced, which I think are more, in my view, more profound over here than I saw in the United States. There's a sort of an acceptance of the little old lady, whereas certainly in California, that's an ideation that's rejected. How do you think that healthcare providers can better support patients in managing the psychological impact of musculoskeletal conditions alongside physical treatments and drug treatments, such like? I
Yeah,
don't know that I phrased that terribly well, but
yeah. I think the first thing to just acknowledge is that it is really difficult. Um, but it's about that research came about because I had two patients, male patients who committed suicide, who both had vertebral fractures, and we started thinking about what the link was and if there was a link. And, these fractures have huge consequences beyond the broken bone. I mean, the biopsychosocial and even spiritual effects. So, they chronic pain from a biomedical perspective, but low mood because of your pain, social withdrawal because you're terrified you're going to have another fracture. Not engaging with the things you used to do before. So it's not really hard to draw the links and the parallels. So I think what can we do for health professionals? It's about having that awareness to spot the signs, not be scared of that conversation. But of course, everything else that we're discussing is relevant as well in terms of just trying to prevent these fractures in the first place or prevent more fractures. But going back to the what can health professionals do in the moment, I think this is something where certainly, you know, doctors who primary care practitioners, GPs, and other healthcare professionals will be better at this because this is their daily sort of bread and butter and things that they do. I think for rheumatologists and the other specialties who manage bone and see people with osteoporosis, for example, or arthritis, it's actually harder because it's something that we perhaps weren't trained in or specialised in. And so we're doing some research at the moment to try and understand what healthcare professionals need to be able to have these conversations. The other thing is that within my own specialty, we tend to be quite biomedically focused and just hone in on the drug. What drug does this person need? What should I be, or would they benefit from? What can I be recommending them? And if you think about osteoporosis, that means that we might entirely neglect the patient's agenda around the symptoms they're experiencing, around pain, low mood, social withdrawal, etc. So again, it's quite a big culture shift needed, really, to change our practice, to be thinking about all of those things in addition to, what's the best drug for us to choose here. So I'm not sure I've answered that question very succinctly, but I think, I'll come back to the first thing I said was that it's difficult and it's not going to
Yeah.
happen overnight, but awareness is really key.
And it's hard in a healthcare system where clinicians have just a few minutes with a patient.
Yeah,
And
absolutely.
the philosophy, Zoe, that I've always had, um, it was inspired, as many of the things are, just like you said, you had two patients who died by suicide. I had a patient who I operated on many, many years ago for an obstructing cicatricial sigmoid carcinoma, presented as an emergency, and I had to do a defunctioning colostomy um, after resecting this in the middle of the night. And the guy attempted suicide. And it struck me at the time that there was the disease and then there was the dis-ease. And I had probably not done a sufficiently good job in explaining that the colostomy was just a temporary measure. But he found it so shocking and hadn't had the chance to because it was an emergency. And it changed the way I thought about how we talk to our patients, because there's the way we perceive the disease,
Hmm.
the you use the biomedical term, which I like, but it's also we perceive it, oh, you've just got a spot of psoriasis, you'll be okay, we'll take care of that. But their self-image, their self-esteem may be
Hmm.
so damaged by the disease that it's causing them, this inner voice, this id kind of circling and criticizing them,
Yeah.
and can lead to, and we know that suicide rates are just, they're high. It's one of the leading cause of deaths, funnily enough. Not funny at all, but it's more common in men, which I certainly didn't know. Anyway, let's change topic a little bit. Arthritis. What's the state of the art in arthritis? What's new and upcoming in the diagnosis and management of what I learned was a wear and tear disease, whereas
Oh.
it isn't, right?
Yeah, so I think our research at Keele, I say our because I'm quite peripheral to it, but the research at Keele, I should say, has really been challenging that explanation that we give or as health professionals and have done for years. And it's kind of a societal term, isn't it? Right, wear and tear. And just to try and bring that up to date with our biological understanding of the disease, which has really advanced, and it is much more than degeneration. There is inflammation and local repair going on. And of course, the phrase wear and tear can be harmful in the sense that when it's received by a patient, if they're told they have wear and tear and then sold, now what you need to go and do these exercises, that makes no sense at all. So that
Yeah.
the explanation uh, and the treatment need to be linked and connected, and so that makes sense as to why that would be helpful. So and in fact, the Keele group are leading now a sort of international group trying to change the narrative about osteoarthritis. There's lots of parallels with osteoporosis actually, in terms of how that normalization with aging means that people believe it's not something that can be modified and treated. So that's the research that's been happening in our institution. But of course, you asked about what's new in the management, and I think it's fair to say that at the moment, in terms of clinical guidelines, there haven't been any massive changes in the therapeutic sort of toolbox, if you like, over the last 5-10 years. But I think there are things coming in the pipeline. So there's some quite exciting stuff around the use of methotrexate, for example, which is a rheumatoid arthritis drug, which has been shown to improve outcomes for people with knee osteoarthritis, I believe. So, and I think there's much more work to do there to understand which patients it is that would really benefit from that treatment. But so that's still, in the research pipeline. But I don't think it'll be too long before that's coming to practice, and that will having a new medicine for osteoarthritis again is going to revolutionise care and mean that care pathways and things need to completely change.
So, question for you. A friend who is taking one of the GLP drugs, um, he was taking it for weight loss. His wife, who has rheumatoid arthritis, was put onto the one of the GL. I won't mention the trade name. This was in the United States, and the rheumatologist there believed that it would help her rheumatoid. That there was, and this woman is not overweight, but she maintains that her symptoms have become dramatically better. Is this just apocryphal, or are there any data that it has an anti-inflammatory or an anti-rheumatoid effect?
I think the
Sorry to
short
put
answer
you
to
on the
that is
spot.
I don't know. I mean, we know that weight loss helps the symptoms of osteoarthritis, but you said she's not overweight, and
It's not, and she's on a tiny dose. And apparently, I just wondered if there were any data. This is just a phone conversation I had
yeah,
2 days ago.
I don't know. Is the short answer. I mean, we know that adipose tissue um, releases cytokines that can be inflammatory. So I suppose in theory, but I'm not aware of the data. I think there's lots we need to understand about those drugs and their effect on muscle and bone as well as inflammation. So yeah,
Fascinating. Apparently, there were shortages of it in America
mm,
because everyone is
yeah,
is on it. And there was, I think it was at the Oscars. One of the commentators welcomed, the host said, welcome to the such and such um, Oscars, or as we like to call it, the Ozempic International Conference. Anyway, in your role as clinical lead at the Hayward Academy Academic Rheumatology Center, you've developed an award-winning fracture liaison service. Tell us about some of the successes and challenges that you've encountered in building that service and how you see it evolving.
yeah. So fracture liaison service is about systematically finding people with that, as you mentioned earlier, thinking about people who have fractured and making sure that they get that bone health assessment. So we're supposed to systematically identify people who are 50 and over who've had a typical osteoporotic fracture, wrist, humerus, spine, hip, and do a bone health assessment and offer medicines and other interventions if it's needed. So I think one of the big challenges for all of these services, and ours has been no different, is how we include people with spinal fractures in that, because people with spinal fractures don't rock up to fracture clinic in the same way that people do who've had a wrist fracture or a humerus fracture, because
Yeah.
most spine fractures don't happen after a fall, only 20% happen after a fall, and most of them are undiagnosed and don't come to clinical attention. So we've been able to work with our radiologists to improve the reporting of vertebral fractures on imaging that's done for other things, like CT scans and so on, for weight loss or other indications. And we screen our radiology reports every week for vertebral fractures and invite those patients in. So that means that proportionately, compared to other services, we're doing really well in terms of the number of people with spinal fractures we're identifying. That brings with it its own challenges, because our nurses then ring up somebody who's got a spinal fracture and doesn't know they've got one, and have to have all of that explanation and things. But actually, often these people with undiagnosed spinal fractures have got severe osteoporosis and are really at risk. So we really are, identifying the people who need it. So that's been, success and challenges wrapped into into one, really. And I suppose it's those sorts of people as well that we're trying to channel for these newer medicines, because we know they'll benefit the most. And again, we've had to reorganise our service a little bit for that. Challenges are always funding. So we're trying to get a sort of sister service in our neighbouring area, and we have been for the last 12 years, and there's just no money, so it's very difficult, even though there's a national mandate now for these services. So that's difficult, and it's not right. There's such a postcode lottery in the availability of these services. And I think you asked about how it will be evolving over time, and I think probably it's a work in progress on how we better integrate with primary care. I mean, we tend to see these patients and start them on or offer them medicine and get them started, and then that follow-up doesn't always involve the patient, probably doesn't always address the patient information needs and so on, and maybe doesn't support our primary care colleagues in the best way that we could. So I think how we can better deliver that's probably something that we need to work on nationally, actually, not just within our service.
Yeah. So switching topics again, everyone talks about social media. I personally view it as anti-social media largely. But you co-authored a paper entitled "Using Twitter, X," strange name I always thought, to mobilize knowledge for first contact physiotherapists, a qualitative study. Talk to us about the responsible use of social media and what you found in your work.
Yeah, so that was a really interesting study. So I should just perhaps clarify that first contact physiotherapy practitioners is a fairly new um, scope of practice, if you like, for physiotherapists. Well, not I suppose it's not that new, but it's physiotherapists who see people at first point of contact in primary care. And so this study was interviewing them about how they use Twitter. And I suppose what we found is that Twitter was really helpful for them in meeting their needs around scientific knowledge, and exchanging knowledge between them. And actually, in the fact that they felt very isolated in the new role that they have and practicing in this new way on their own. And actually, it was a great way of connecting and getting reassurance from others, but also learning about new scientific developments and things. So those were the pluses, which perhaps are not so surprising. I think what we found about the challenges of the social media, which I was not surprised at, others I was. So that it obviously people talked at and were aware of the kind of idea of the bias and echo chambers, and that you're only sort of hearing the narrative of who you follow, which is perhaps not a surprise. But what really struck me was that they were also, in a way, fearful of using it because they'd seen really unprofessional behaviour from their colleagues. And so other health professionals who were saying things on Twitter that they thought was really unprofessional. And also this fear and discomfort they had from patients following them, or and looking at what they might have posted. So for some people, that really sort of paralysed their use of Twitter, in that they would be what we call lurkers, where they'd be looking and watching, but absolutely, terrified of posting anything themselves for fear that they'd say something unprofessional, or that something a patient would hook up on.
It really is. It's scary stuff. I started doing a podcast for the lay public, and with a dear friend and colleague, and the 23-year-old who's been helping us, she's developed social media posts and edits and uses clever things that we didn't know they were clever when we said them, to hook people. And suddenly you've got 100,000 views of something. So I can see if you use it responsibly. And, what gets me is stuff like the so-called vaccine hesitancy and pseudoscience that gets, dished out. Anyone is now a journalist. Anyone is now an expert. And I'm worried about it. I don't know how we better police it, but I think one way is just overwhelm social media with high quality stuff on healthcare, so that the garbage gets flushed out. Zoe, one last question I like to ask every guest. If they came across a magical genie who could grant 3 wishes in your area of healthcare, what might those wishes be?
Okay, so I'm going to focus on common musculoskeletal disease, which we've been talking about earlier, because I think it affects most people and is, where we can do the most good. So my first one would be that osteoporosis is better prioritized in healthcare, I think, for all the reasons that we've spoke about, so that the people who are most at need of assessment and treatment get offered that. The second is for osteoarthritis, that everybody who's got it gets a proper diagnosis and explanation of what it is. I think that's so important for engaging with treatment and management. And then I guess my third one spans both of those, is that a shared decision-making and person-centered approach would be business as usual, which it so isn't at the moment. And I think really what matters to the patient is the most important thing that we should be addressing. And, I'd really like to see much more of a culture shift there.
Well, those are all very attainable. And I'm sure that if anyone's going to get it done, you're going to get it done. Professor Zoë Paskins, thanks so much for taking the time to talk to us. I hope you enjoy the book about Inside of a Dog and continue doing what you're doing, because these are common conditions for patients, and we're all going to be patients sooner or later. So, Zoe, thank you so much.
Thanks very much. I've really enjoyed our conversation. Thank you.
Yeah, lovely, lovely work. It's lovely for me. I get to go to bed less done tonight. So, to the folks listening, if you're not already a subscriber, please subscribe on Spotify, Apple Podcasts, or wherever you get your podcasts so you never miss an episode. Tell your friends, colleagues, leave a comment, like us. I'm told that helps. So, and please join us next week for another fascinating episode. Until then, I'm Dr. Jonathan Sackier. Thanks so much for joining us. Please stay safe, stay well, stay curious. Bye for now.
Well, that concludes our 3-part series. Thank you for listening, and we'll see you soon in the next deep dive series.